Okay, welcome back to F-Tag Journal. This is going to be a quick and easy one. F552 is about right to be informed and make treatment decisions. So, table of contents, quick overview, citation history, go over the interpretive guidelines, what the surveyors are going to look for, actual citations based on our research, and a quick summary, and then we'll be done. So, brief overview. It's a very short F-tag. We should be able to get through it pretty quickly. There is a lot of variation in the citation. That'll probably take up the bulk of the time on this video, is just giving you all the examples that we have from reading, this particular F-tag, hundreds of 2567s about F552. And then as we go through it, you'll see that most of the citations are related to a lack of documentation. So let's give you a little citation history. In 2018, F552 was the 81st most cited F-tag in the country, and that was only with 303 citations nationwide. 2019, the ranking stayed pretty consistent, as did the raw number, coming in at 82 and only 301, so 2 less in 2019. As far as whether it was a complaint or annual survey, just about 75% of the citations were issued during the annual survey. So scope and severity, overwhelming majority, like most of the F-tags, are at the D level. A few got pushed into the E scope and severity. And then you can see that there's 3 G tags and 1 J tag. I don't think there's a couple G tags I think we may cover in the examples, but I won't get ahead of myself quite yet. As far as the state distribution, looks pretty normal. The only thing that stand out to me is Massachusetts, that has 300 and some facilities, 330 I believe, and they have 21 citations. And then you look at Texas, they only have 19, yet they have 1,200 plus facilities. Another one I look at is my home state, Washington, 38 citations, and they only have 220 facilities in that state. So, the least cited states, there were 15 states with no F552 citations, and then Missouri, Virginia, Tennessee, and New York all had 0.3% or less. So the most cited states: Alaska, Washington State, as I mentioned, Nevada, Montana, and Oregon, rounding out the top 5 for the most cited states in terms of percentage of number of facilities in their state. So the interpretive guidelines: the resident has the right to be fully informed and participate in their treatment. And they need to be informed in a language they can understand regarding their total health status. In the next couple slides, we'll give you what the definition of total health status as far as what the interpretive guidelines has defined it as. Resident also has the right to be informed in advance of what care will be provided and by who. And I don't mean by, okay, the care is going to be provided by Pete Wilson or Susie McCreary or whatever. What I mean by is, okay, you're going to have your wound care provided by a wound care nurse, or you're going to have therapy provided by a professional physical therapist, that sort of thing. So the resident also has the right to be informed in advance by a physician or other practitioner. That can be a nurse practitioner. That can also be a professional like a registered nurse. And they need to be informed in advance of the risk and benefits of the proposed care, as well as treatment and alternative options to the proposed treatment, and they need to be allowed to choose their option. Okay, some definitions given by the interpretive guidelines. The first definition is, what exactly is total health status? What does that include? Well, that includes your functional and your nutritional status, That includes your rehab and restorative potential, includes your cognitive, oral, and psychosocial status, as well as any sensory or physical impairments. So treatment, what is it defined as in the interpretive guidelines? Well, it's any nursing care or medical care and the interventions that are used to maintain or restore your health and well-being. It also includes any interventions used to improve your function, or if possibly you're on hospice or something like that, or you have a terminal illness or chronic pain, any interventions used to relieve your symptoms. So health information needs to be communicated to the resident or the resident's representative or responsible party in plain language, and that includes explaining medical and technical terminology in plain words. Translation services must be available, so if English is not the resident or the responsible party's primary language, there's a lot of services out there that can provide translation services. So that does include foreign language as well as sign language. Accommodations must be made, attempts must be made to communicate with the hearing impaired. Again, auxiliary auditory devices can be provided, whether it's a dry erase board, something to that effect, but it does not require the facility to pay for hearing aids. And last, as far as communication, and this doesn't necessarily communication to the resident or the resident's representative, but communicating to the surveyors or anybody else that is looking at the medical record, documentation needs to be completed thoroughly. And as far as treatment and the decisions made, you need to document the options that were discussed, as well as the residents and the responsible parties' decisions in the medical record. So there's some cross-tagging potentials with F552, and the two most likely is F578, which deals with right to refuse, treatments, that sorts of stuff, as well as advanced directives. And then F655, which is comprehensive person-centered care planning. Okay, we'll go through some actual citations. Looks like there's a couple B, one B, one C, and then the rest of the page are D's. Following slide will be a majority of D's as well, with a few E's and then G's and J's in there. So the first one, no documented evidence that risk and benefit was gone over for a medication with a black box warning. So no evidence there was a discussion. Resident had bed bugs. They had to move the resident to take care of the bed bugs. The responsible party was told that they were just cleaning carpets. No risk and benefits for an antipsychotic medication. Resident was not informed why they were moved to a secured unit. Resident wanted dental care. Resident was not told why he was not seen the last dentist visit. Resident discharged home. No consent before starting an antidepressant. No consent for an increased dosage of an antipsychotic. Resident was straight cast without permission. A consent form was signed and dated 2 months after starting the medication. Side rail consent was not signed by the facility representative. Last minute dosage change, but no new consent form had been completed. So they had done a consent form with a dosage, and then at the last minute they changed it. So the old form had a incorrect dosage, and they didn't do one to update the dosage. No consent for decreased dosage of antipsychotic. Resident requested options for reversing their colostomy, and the facility did not provide them with any options or alternatives as far as dealing with reversing the colostomy. Resident complained of being informed of appointments on the day of the appointments, so no advanced informing the resident of appointments in advance. Responsible party not informed of resident fall for 2 days. Resident was not informed. Resident or responsible party was not informed that hospice was an option. The doctor increased dosage against the responsible party's wishes. So in that case, it's not allowing the resident or the responsible party to choose their treatments. Ignored responsible party request for 2-week monitoring after an increased dosage of a medication. Facility performed CPR on someone who was a DNR. No consent for an anti-anxiety. Insulin refused, and I don't mean just one dosage. The resident altogether did not want to take insulin, and no alternatives or risk and benefits were discussed. Resident complained they were completely unaware of the care plan. Resident was not informed that their over-the-counter medication was decreased to once a day. A Spanish-speaking only resident had no idea what pills they were taking. Resident was given a drug screen, but the guardian was not informed, and they did not give consent. Resident was unaware why they were transferred to another facility, and the resident was also unaware that they had appeal rights. No consent for a restraint, and in this case, the restraint was the bed against the wall. No consent for restrictive socks and mitt. No notification of the responsible party of an increase of 7.4%. No notification of a 7.4 weight loss in 1 month. No notification of a discontinue of an antipsychotic. No notification to the resident. The resident had no idea. Resident was also not told of a new medication starting. No nom-knock was given in a language that the resident could understand. This particular resident only spoke Mandarin, and there was no Mandarin way to communicate with the resident and let them know that their benefits were soon ending, their therapy was soon ending. Resident was not informed why they were wearing TED hose. No documented evidence that code status was discussed. Sign language resident complained that they were completely unaware of the care plan. Resident was not informed that they had received the wrong medication, so in this case, they gave Mrs. Smith somebody else's medications, and then they never told Mrs. Smith that she got the wrong medications. And there was no risk and benefit given to a resident who refused to have their lumbar x-rayed as ordered by the doctor. Okay, some more D's. Let's see. Resident not informed of the splint schedule. What I mean by that is a lot of people will wear a splint on their hand or whatnot for 6 hours a day, and that's it. And they were not informed of when they were supposed to wear it, for how long, or anything like that. Not informed of therapy schedule. Did not accommodate the resident's request for a MedPass schedule change. Resident was not informed of x-ray results. No consent for a WonderGuard. Not informed of a MedPass time change. Nurse did not answer the resident when the resident asked the nurse what the pills were for. Resident did not receive a copy of the admission packet. Family signed hospice consent, but the resident was not incapacitated. Resident was not informed for the reason for a room change. Facility did not honor family request to send resident to the ER. Wound care performed despite the resident refusing wound care. This one, there was no attempt by the facility to accommodate a soup request when the resident was on a fluid restriction. So say the resident was on, 1,000 cc's of fluid a day. Maybe they got 100 with each meal. They should have, found a way to take a little fluid away from meals or whatever, and rather than have it in water, just put it in soup. Easy fix. Resident was not informed that they had more than one hospice company option. Staff failed to schedule a follow-up cardiac appointment as was requested by the resident. Responsible party was not notified that the resident was put on a one-on-one observation with a sitter. There was no timely notification that the resident was transferred to the hospital, and in this case, the responsible party was unable to help with treatment decisions at the hospital. So here's an E-level scope and severity citation, and you can tell from these E's that there's not going to be a whole lot of difference between an E and a D. So on this one, there was no doctor, no physician or responsible party notification of a choking episode. No consent for Tamiflu. Resident was not informed students would be assisting with cares. Resident was not discharged to the streets as the resident wished. Resident was unaware that they had an order for a heat pack to assist in relieving pain. And an Alzheimer's diagnosed resident was signing their own documents. Lower extremity amputee complained that they had no say in their pain management decisions. You can easily see that if an amputee, there's certainly that scenario right there as the potential for it being circumstances where there was some narcotic abuse, but I don't recall the specifics on that one because they just basically said resident felt that they had no say in their pain management decisions, and so they got F552 cited. So we move on to the harm tags. Responsible party was not informed that the resident had right-sided weakness for 4 days. A resident was not informed in advance of a new psychologist. In this scenario, resident was seeing a therapist, psychologist, and they really were shocked when one day a new psychologist came in and they took it as a huge insult and they were deeply offended, and they ended up citing a harm tag because the resident made such a big issue out of it. And on this one, there was no notification of the responsible party of medication errors. And then the J tag, family was not aware that they could revoke hospice services and send the resident to the hospital for very aggressive wound care. So just a brief summary here. We'll just wrap up, explain what you need to do to avoid getting F552 citation, and it's pretty simple. Just explain to the resident and responsible party what the treatment options are, and do so in plain terms in a way that they can understand. Even if they gotta, speak a foreign language or sign language, find a way to communicate what the treatment options are. Next, you got to let them make the decision on what the treatment options are, even if it doesn't make sense, even if it's against, recommendation of the medical provider. Provide them with a risk and benefit documentation and get a consent form signed. And lastly, document it all. And this is the old adage in long-term care, skilled nursing, is if you didn't document it, then you didn't do it.